In the meantime, I want you to hear about the ethical framework from Sarah McGraw. Sarah is the Director of Program Development and Senior Research Scholar at the Hastings Center. She's a medical anthropologist and is the principal investigator or co-principal investigator on a number of publicly supported grants and contracts, including the project titled Returning Individual Genetic Results to Participants in Cohort Studies. And I know she's also actually engaged in some ethnographic research right now as an anthropologist. So please welcome to the podium Sarah McGraw.
Well, good afternoon, everyone. I thank you for inviting me here, and I wanted to also thank you for holding this meeting and talking about translational research, both through the CTSAs as well as sort of more broadly. And one of my hopes is that maybe out of this will come some increasing emphasis on conducting this kind of research more broadly. So in response to what Drs. Aronson and Barron had to say, and what we've been hearing today, I wanted to try to draw the link a little bit between translational research and learning healthcare systems before I got into the discussion about the ethical framework that was published recently in the Hastings report. So you heard I'm an anthropologist and at the Hastings Center. And so you've been hearing, and Lauren was just talking about translational research, and Elias Zerhouni's definition of it originally was the translation of scientific innovations into health gains. And then I'm going to skip talking about the CTSAs because clearly Lauren did that, but just note that they've become very important academic homes across the country, as she said, for integrating resources to support this kind of work. Lauren went over the NIH definition of translational research, but I wanted to point out one additional point, which is that this definition also includes determining the cost effectiveness of prevention and treatment strategies, so it doesn't stop looking at the adoption of these practices, but are they cost effective or not? Lauren talked a little bit about the T1 to T4 terminology, which I think people sometimes use a little bit differently across the country, but I wanted to sort of just make the point that this rubric of translational research really includes at least 4 distinct types of research. So there's the bench research, as Lauren talked about, the clinical research where it progresses into humans, and this research is intended to establish efficacy in drug efficacy or device efficacy. Did a drug or a device work or not? And then comparative effectiveness studies, which take these promising kinds of interventions and test them head-to-head to determine whether or not they're better for some groups or another, or if they're more cost-effective enough than some treatment or another. So comparative effectiveness research, actually, I think some people define this very broadly to include everything from knowledge synthesis to observational studies, including the use of big data or administrative data, the use of QI registries, the comparison of head-to-head comparisons of drugs or devices. It can be the comparison of 2 or more ways of delivering care, but it also can be the comparison of different kinds of dissemination or translation methods to be sure that there's an uptake of these new evidence-based findings. So I wanted to return to this research spectrum that I'm building and add a 4th type of research, which I don't think we've mentioned much here today, which is the what some people are calling implementation science. While translational research is intended to encompass the full spectrum of research from bench to clinical trials to CER, it also includes implementation science, although I think until recently, most of the emphasis has been on the left-hand side of this spectrum. I think now people are recognizing the push towards moving to the right-hand side of the spectrum. And in fact, actually, there's a new journal out, I don't know if some of you have heard of it, called Implementation Science, where it provides a forum for publishing these kinds of studies. And that journal actually defines implementation science, the uptake or the study of the uptake of evidence-based practices. And I think it's a good way to promote an emphasis in this area. So one example of an implementation science study could be one that's aimed at finding out how to best encourage the better management of hypertension, for example. And it could be designed as a CER study, as we've heard today from a couple of people, comparing two methods of encouraging clinicians to use an evidence-based practice. It could also be designed as an observational study to understand the barriers to the implementation of this evidence-based practice. So that's where learning healthcare systems come in, I think. And a learning healthcare system, as Dr. Payne talked about, are really systems that examine their own practices. They gather data on their patients and they gather data on their clinicians as well. They use that information to make a change and they evaluate the impact of these changes. And they also, importantly, I think, and this was mentioned for the CTSA, engage patients and communities in thinking about how this research should be carried out, what are the implications of this research, how do we interpret the findings, and what kinds of changes should be made. We've seen earlier today a little bit about the IOM reports, and the IOM has been essential in sort of pushing the recognition of this idea of learning healthcare systems and understanding what works best with evidence-based medicine. And they've published actually a number of reports that relate to this area, so if you're interested, you can find them online. In addition, I think the recognition of the importance of learning healthcare systems has been gaining traction in part due to the work of the American Medical College, the Association of the American Medical Colleges, or the AAMC. And interestingly, they did a study back in 2010 where I actually was involved in this study, conducted a series of in-depth interviews with representatives of medical schools across the country and teaching hospitals to understand how they were focusing their research on improving the care of their own patients. And through this study, the AAMC identified numerous institutions that are now funding and hiring new people to gear up and to begin doing CER and implementation much more systematically. So I think that's where these two movements, the CTSA movement and with the recognition of the full spectrum of translational science, and the IOM, which helped to bring attention to the importance of the learning healthcare systems, sort of come together. But I think there is actually one sort of big barrier that's sort of inhibiting our ability to push this idea along further, and that's sort of the lack of consensus about the nature of the ethical oversight of learning healthcare systems. And so currently now there's a very big debate about what that should look like, and I'll talk a little bit about that shortly. But some of the questions that are sort of being debated are at what point does a patient become a human subject? Is data collection research or is it quality improvement? What needs IRB review? So to explore some of these questions, as Dr. Payne alluded to, the Hastings Center report recently published a special supplement called The Ethical Oversight of Learning Healthcare Systems. And actually I left a few copies back up there, and I think all the participants have a link to one of the articles. And there are also some, in the effort of advertising the journal, I left some information about how you can subscribe to this journal if you're interested. So this journal actually featured a number of articles, but the two main companion articles were written, the first by Nancy Cass and her co-authors that sort of explored the issue of the distinction between research and treatment, and then also Ruth Faden and her authors who tried to lay out a framework, an ethical framework for the learning healthcare system. So this Hopkins team, which produced these articles, believes that the traditional framework we have currently for protection of human subjects in the United States is really not coherent any longer. And as you all know, probably for many years, since the Belmont Report, bioethicists and federal regulations have drawn a sharp line between what's research and what's treatment, defining research as those activities that are intended to develop generalizable knowledge and require systematic investigations. But as research becomes integrated into healthcare and clinical practice, and as these learning systems use healthcare practice as a continuous source of data, this demarcation begins to blur. So the Hopkins team, you may not be able to see this very well, and I'm not going to go through it, I just want to show you, thinks that we really need to rethink this demarcation. And in fact, when they talk about learning healthcare systems, they don't talk about care and research. They don't use those words. But they introduce this label of what they call learning activities. And these activities are intended to encompass a collection of data about patients and or about clinicians to provide insight into how to improve care. They also believe that a new set of criteria should be used to guide the IRB. And what they propose is that it's not whether or not something is a systematic collection of data that will lead to generalizable knowledge. What they propose rather is that the level of risk for whatever the learning activity is being proposed should be the primary consideration for whether or not it goes to an IRB. So low-risk protocols, in their view, should not need IRB approval, although some entity somehow will have to determine what is low risk and what is high risk. And if it's only moderate or a higher level of risk, protocols then would advance to the IRB, and hopefully that would eliminate some of the encumbrances to this kind of work. I also want to point out that this is somewhat of a controversial proposal right now, and there's a lot of debate around the obligations of this ethical oversight. And some people have cheered this new proposal and think it's a great idea and are recommending that DHHS revise their guidelines along these lines, while other people, including commentators in this special issue of the Hastings Center report, thought that they're going way too far, and that some of these demarcations between clinical practice and research still are legitimate and still hold up, and that some of these kinds of studies will need more review than they're suggesting. So one of the major areas of dispute, for example, is whether or not a study which randomizes people or patients or clinicians, even if it randomizes people to two different arms, as we've been talking about today, both of which represent acceptable standards of care, can these be done without consent? And I think maybe there's a following session or presenter that's going to get into some of that. Some have argued that randomization per se, regardless of whether or not it's to two acceptable arms, still requires consent, just because people need to know that they're being randomized, and you can't sort of eliminate consent altogether. But I just wanted to mention this because this is one of the very much hotly contested debates currently in the area. And then another interesting area that actually wasn't covered in this ethical framework, which the CTSAs deal with to some degree, but I think needs to be added more actively, is this discussion of the role of the patients and the community in setting the agenda for learning activities. So there has been a sort of a considerable emphasis on defining patient-centered outcomes, and that's been a big focus of PCORI for a long time, and in developing outcomes that are meaningful to the patients. But there's really been a lot less deliberation on how communities and patients should actually be involved in setting the agenda for learning activities. when do they sit at the table with clinicians or scientists to identify what the important question is, to interpret the findings, and then to think about how to translate the results into practice. So I think that I would argue is something that needs to be added to this framework in a more considered fashion. So I think fundamentally what to remember is what's at stake here is sort of the tension or the balance between being able to determine is care effective, is it equitable, and does it minimize costs at one hand, but at the other hand, protecting the interests of persons, which includes patients and clinicians who are involved in these learning activities. So in conclusion, I think there needs to be certainly some rethinking of regulatory practices, some consideration of what is the threshold at which learning activities require ethical oversight. One issue, I think, is the whole area of quality improvement, which has its own sort of area of debate on this issue. But when does quality improvement require some form of ethical oversight? And then how do we balance supporting these learning activities with protecting the interests of the human subjects or the people who are being observed?
Are we out of time? We're out of time. Pretty much out of time. Yeah, we are. Thank you, Sarah. Just as a kind of a follow-up to that, and not to shy away from controversy, as the Center never has, I don't think, in its 30-year history, we're going to be taking on some of the challenges that she just referenced in Kansas City, and we're going to be working hopefully with the CTSA in helping explore some of those issues. So our objective will be actually to, over the course of the next few years in working with the CTSA, is to actually construct an ethical framework for assisting health providers in all those spectrums of research, including comparative effectiveness training as well as the quality improvement, and basically participating and identifying with patients what's their role, what's their obligation, and how can they actually participate in helping identify some of those outcomes. So we've got 5 major objectives that we're going to be working on, hopefully over the course of the next few years on that. Obviously, the first round of that will be support that we receive from PCORI on the 3, I think we're actually got 3 or 4 different PCORI proposals that we are either partnering with or submitting on our own. So we'll keep you posted on that and hopefully be updating you in the first part of next year at our April annual dinner meeting, where we'll be talking a little bit more about this in more detail. So with that, I'll conclude this session and turn the program back over to Dr. Payne.